Patient marking begins when the surgeon evaluates the patient's area of concern for facial grafting, the face or anywhere in the body. In this patient, fat grafting to the mid-face and other areas of the face will be performed. Marks are performed using either a white pencil or a purple surgical marking pen. Classically, with the aging process, patients lose fat in the tear trough, nasal jugal groove, nasolabial fold, submalar areas. Additional loss may occur in the mesolabial folds, the upper lip, the lower lip, mental crease, or other lines on the face. In facial fat grafting, the best form of anesthesia is facial nerve blocks. This enables the maximum surface area of anesthesia to the face with the least amount of lidocaine, lidocaine being lipotoxic to the fat cells. Incisions are made with a 1 mm dermal punch. The minimal number of incisions are performed. Classically, the infraorbital area, the inferior aspect of the nasolabial fold are areas preferred. Occasionally, field blocks are necessary, such as above and below the nasolabial fold. The main advantage of the body jet is that fat acquisition occurs with no purification of the collected fat. The fat is collected by a 10 or 20 cc syringe and transferred to 1 cc syringes for injection in the face or body areas. Fat grafting microcannulas 1.2 to 1.8 millimeters in size are used for grafting to the face. Micro droplets of fat are distributed along the areas of volume deficiency. Here, at the nasolabial fold, besides micro droplets in a linear fashion, a fanning technique is used to deposit the fat both inferior along the nasolabial fold and superior to the nasolabial fold. This presentation illustrates facial fat grafting. However, the tremendous advantage of the body jet is the significant amounts of concentrated fat that can be acquired without any purification. This large amount of fat can be injected anywhere in the body, including the breast for repairing asymmetries or producing a mild augmentation, filling in areas of depressions and indentations, such as with cellulite, and augmenting the buttock area, producing a Brazilian butt lift. It can be observed here that with facial nerve blocks and field blocks, the patient is very comfortable during the fat grafting process. Here, the mesolabial fold is being injected. The most difficult area for fat grafting, secondary to the thinness of the skin, is the tear trough area. Caution in the amount of fat injected in this area is paramount. Slow movements to and fro with minimal injection of fat is preferred. One can also use a Jaeger eye shield to protect the globe of the eye from injury. I prefer to inject linear areas in a perpendicular fashion to prevent a linear augmentation appearance. As observed here, we use a very small micro cannula measuring 1.2 millimeters in size to inject a very small aliquots of fat. During the fat grafting injection process, it is important to continually reassess the area injected with fat. Palpation and vision both help in this regard. Areas of excess fatty administration can be smoothed by using the surgeon's fingers. Alternative methods of smoothing fat cells can be used, including the 1 cc syringe rolled over the area of prominence. The submalar is an area where large quantities of fat can be deficient, with the aging process absorbing the buccal fat pad. Classically, the larger microcannula is used, 1.8 millimeters in diameter. Anywhere between 3 cc's and up to 10 cc's of fat can be placed in this area. As seen here, the skin is undermined prior to injecting the fat to ensure a smooth layer. It is recommended not to inject more than 1 centimeter in diameter in terms of the quantity of fat in one location. The reason for this, it enables the fat cells to receive a blood supply before they become necrotic. I prefer to inject one side of the face and then the same anatomical area on the opposite side of the face and look for symmetry. Often, patients' faces are asymmetric and more fat is placed on one side of the face than the other. Lip augmentation is often achieved to the one inferior placed nasolabial fold for both the upper and lower lip. One must ensure that the upper lip is 2/3 the size of the lower lip. Due to the tight compartment of the lip, rarely can more than 3 to 4 cc's be injected in one entire lip. When augmenting the lips, be very careful not to puncture the inner mucosa, as this can cause extrusion of fat cells through this injury. The lips are the only area of the face when I perform fat grafting that I actually inject lidocaine into the area to be grafted. The reason I inject local anesthesia into the lips is that the lips have a vast blood supply which can cause bruising and bleeding during the procedure. I put the smallest quantity of lidocaine possible to produce anesthesia in the lips. Again, one can see I use bimanual palpation of both the inner mucosa and the outer skin to ensure that the microcannula is placed properly in the submucosa of the lip. A fanning technique is used to deposit fat from the inner mucosa towards the central part of the lip and then towards the skin. Rarely people prefer the mental crease to be blunted, and this is performed using a larger cannula, 1.8 millimeters in diameter, to deposit fat cells along the mental crease. Classically, patients have bruising for approximately 1 week after the procedure, and it's classically mild. Swelling from the surgical trauma usually lasts 7 to 10 days. Fat cells absorb slowly over time, and after 12 weeks, their absorption is stabilized. Studies, including those by Sidney Coleman, the modern developer of fat grafting, reveal that the appearance of the injected fat site is unchanged between 12 weeks or 3 months and 6 to 8 years post-injection. I hope this brief video presentation on the complete process using water jet assisted liposuction or the body jet has been both informative and helpful in introducing you to this revolutionary new technology in body contouring as well as face and body fat grafting. Thank you for your interest.